Education through geriatric psychiatry. Today, we are fortunate to have with us one of our subspecialty residents in geriatric psychiatry, Dr. Lauren Haslam. Lauren has an undergraduate degree in pharmacology and worked as a pharmacist, did her medical school and psychiatry training here at Dalhousie, and is finishing off a subspecialty residency to become a geriatric psychiatrist. I would just remind people that we'd like you to keep your mics and videos muted or off during the presentation. There is a chat box if you'd like to put anything in the chat box. We will get to those questions and comments at the end. The presentation will be available afterwards, and it is being recorded. If you would please just press the button to say you're okay with being recorded, but just make sure that you don't say anything you don't want other people to know for the next 20 years. And with that, I will hand it over to my colleague Lauren Haslam to talk about pharmacology in the older adult.
Okay, yeah, thank you, Sarah. So yeah, I'm going to talk about pharmacology with some considerations in older adults. Um, so the objectives, I'm going to talk about pharmacokinetic parameters, including absorption, distribution, metabolism, and elimination, and as well as pharmacodynamic concepts like mechanism of action, half-life, potency, and efficacy, as well as adverse effects. And I have included a case to try to illustrate some of these concepts. The focus is not going to be on equations, though, or that sort of thing. So you don't need to worry about that. It's kind of just the basic concepts. For this, it had been a little while since I had really thoughtfully in a pharmacology way rather than just sort of like a medication-centered way. So I used some textbooks on pharmacology, as well as up-to-date and a Merck manual, as well as some other websites to put the presentation together. It is a new slide deck, so feedback is welcome after the presentation. So, with pharmacology, it's the study of the origin, nature, the chemistry, effects, and uses of drugs. And drugs are chemicals that are used to cause an effect on the body. So, the drugs could include like recreational drugs, or what we are more so thinking of are medications a lot of the time. And the two main kind of concepts that you may have heard about with pharmacology are pharmacokinetics and pharmacodynamics. And I know there's something that I always need to review each time I learn about these things. So hopefully we can reintroduce them. So I put together a little basic case to illustrate some of these concepts. So Miss S is an 85-year-old female admitted to hospital for an upper GI bleed. She presents as hypotensive. She's found to have an acute kidney injury and low hemoglobin due to the bleed. She is quite thin. Her BMI is 19, so in the low normal range. And she does have a history of some mild hepatic impairment related to non-alcoholic liver disease or steatohepatitis. For her medications, I couldn't help but put some psychiatry kind of medications in here. So she's on sertraline at a high dose, 200 milligrams in the morning. She has some mild depression and anxiety. She also takes bupropion, 300 milligrams, so the usual sort of maximum dose or one of the higher doses. She takes lorazepam for anxiety about twice a week and ramipril, an ACE inhibitor for hypertension. So she's fairly healthy overall at baseline. But when you do her best possible medical history, you also learn she's taking some over-the-counter medications that aren't on DIS. So she's been taking ibuprofen, 400 milligrams 3 times a day over the past 2 weeks for some new back pain. And she's also taking diphenhydramine, 50 milligrams at night, most nights over the past 2 weeks because she's not sleeping due to this back pain. And she's also taking aspirin once a day just for kind of general health. She saw that on the news before, but she hasn't had a previous stroke or heart attack. So when she presents, GI is consulted, they investigate the bleed, they treat it with endoscopy, and then she started on pantoprazole IV drip and also given 2 units of packed red blood cells for her blood loss. And we'll pretend that we're the first year resident, like I was on the MTU and reviewing her medications when she comes up on the unit. And we're quite keen on her pharmacokinetic and pharmacodynamic contributors as well. Maybe we've done a pharmacology block recently. So when we think about medication use in older adults, some US data here is that a third of older adults in community were on 5 or more medications. 5 or more medications is often kind of considered as a number for polypharmacy. So like that word being on multiple medications, sometimes too many medications, and sometimes medications that are unnecessary. But in patients that are discharged from hospital and going to a place like a nursing home, they are on an average of 14 medications. So that's probably a lot like what you're seeing for patients who have been in the hospital right now, where things are quite acute. And then it's important to remember that older adults may also be using natural products that can have drug interactions. So, an example was on a case that I saw last year on fellowship. There was a lady taking one Costco-sized bottle of muscle relaxants every week with Advil or ibuprofen that can impact kidney function, and she had significant kidney function. And she was also confused in taking a muscle relaxant, which can be quite sedating. So it's important to ask about natural products or over-the-counter products. And of course, polypharmacy in older adults significantly increases the risk to have an adverse drug event, so like a side effect, or even need to be hospitalized from something like maybe a GI bleed in our patient case. And drug reactions may be responsible for somewhere around 3 to 10% of hospitalizations in the US. And when we think about accidental overdoses leading to hospitalizations, the most common medications associated in the U.S. With accidental overdose related hospitalizations was warfarin, which makes sense, blood thinner, antiplatelets, so things like aspirin or clopidogrel, as well as things for diabetes, so insulin leading to hypoglycemia or oral hypoglycemic agent overdose. And then the most common reason to be admitted to hospital for an adverse drug reaction or event, say like in our patient case, was NSAID. So she had recently started an NSAID. So I have a quick video on pharmacokinetics and dynamics. I thought it was a good video. It's from a legal team, which is sort of interesting, but I thought it covered things well.
Pharmacokinetics and pharmacodynamics. Other than two big words, what are they? Simply put, pharmacokinetics is the study of what the human body does to medications. Pharmacodynamics is a study of what medications do to the human body. Pharmacokinetics is a study of the path a drug takes through the patient's body, how the drug is absorbed, where it is distributed within the body, how the body breaks the drug down, and eventually eliminates it. Pharmacokinetics can tell us how quickly the medication reaches the bloodstream, how much of the ingested dose is actually available to work within the body, how the drug is cleared, and how often repeat dosing is needed. Pharmacodynamics is the study of the drug's effects within the body. These studies help scientists predict what actual clinical effect the drug might have in patients. Both pharmacokinetics and pharmacodynamics are key to developing life-saving medications and are the first human studies done in a clinical drug development program. I'm Michelle.
So then she introduces herself. So pharmacokinetics, what we're thinking about that is the movement of drugs through the body with the processes of absorption, distribution, and metabolism, as well as excretion or elimination, and then also some parameters, things like onset of action and the duration of action. So pharmacokinetics, we're thinking kinetic meaning movement. So pharmacokinetics is the drug's action as it moves through the body and what the body does to the drug. So it involves absorption, distribution into the tissues, metabolism, And then there can also be metabolites in the tissues and then elimination into urine, bile, or feces. And this is sort of a repeat of those concepts. So with the absorption that's taken in, it's distributed into the blood, but also into other tissues like fat or muscle. Um, Medications or things that are taken into the body usually aren't just excreted or eliminated in their original form. They usually need to be changed in some way, and then they can be broken down and then eliminated from the body, either by the kidneys or in bile or feces. So, thinking of things around pharmacokinetics and absorption, it's going to vary depending on the route of administration. So, we think of enteral meaning into kind of the GI system. So, that's going to include routes like oral or sublingual, parenteral, so not in the enteral system. So things like IV, IM, or subcutaneous. And then there are other ways to administer drugs, like by inhalation, say for puffers, nasal inhalation for nasal steroids, or things like midazolam, topically onto the skin, acting locally, or transdermal, moving through the skin and into circulation, or rectal. So absorption is going to vary a bit depending on the route of administration. So if we want a really rapid effect or absorption, we're going to use something like an IV route or sublingual over oral or an inhalation. So think of like things like nasal ketamine or naloxone acting very rapidly and with easy access. And then absorption is going to be slower by routes like through the mouth, having to be absorbed into the muscle or subcutaneous, because then you may need to go into the mucosa muscle, etc., and then eventually move into the blood vessels and bloodstream. We're going to talk a little bit about first pass metabolism as well. So if we take a medication by mouth, especially, the entire drug does not reach our bloodstream to be used for drug effect because it goes from the stomach and then actually passes to the liver and is metabolized to some extent, and then it goes into the bloodstream. And that's called first pass metabolism. And when we take medications, especially by mouth, we're often thinking of bioavailability. So this is the fraction of administered drug that reaches the systemic circulation. So IV medications, because we're injecting those directly into a blood vessel, they have 100% bioavailability. And for the oral route, bioavailability can be quite a bit lower, like say 50%. So I think of something like hydromorphone. It has a lower bioavailability by mouth than IV. So you need to about double the dose orally to get the same effect or concentration in the blood as the IV. I'm just going to repeat this a little bit just for clarity. So oral medications, they pass through first the stomach, intestine, then blood vessels to the liver. The liver will then metabolize the medication to some extent before it enters general circulation. Thinking about older adults, so even in healthy adults, the first pass metabolism is going to decrease with age, so about 1% per year after the age of 40. So older adults, even if they're healthy, may have a higher bioavailability or higher concentration of circulating drugs, even at the same doses as if they were younger or when compared to younger patients. So, around the different routes of medication administration, if we think about oral, we use this commonly. It's convenient, it's inexpensive, but it is subject to the high acidity environment in the stomach, which makes it unsuitable for some medications that would be broken down in the stomach, like things like insulin or other kind of protein molecule-based medications. If we use the sublingual route, then we are being absorbed through the mucosa in the mouth or in the cheek, and this prevents destruction or transformation in the stomach or small intestine. We can use topical or transdermal. So topical is more so for if there's like a local rash that we're treating, but transdermal is, say, a patch that we put on to be absorbed through the skin and into the circulation, things like the nicotine patch or fentanyl patch. It's easy to use this. This will avoid first pass metabolism, which is nice. For respiratory or nasal inhalation, this is a rapid effect. It's useful in emergencies because you don't need to establish any IV access or have a needle or supplies, and you're also avoiding first pass metabolism. When we think about injections, they have great bioavailability often. They can be have a rapid effect, but you're going to need somebody skilled or trained to use this technique. And you're going to need some time or supplies. So there's a bit of an inconvenience, but it does allow you to bypass the GI system and first pass metabolism. This would be suitable in our patient case. She's having a GI bleed. So in those cases, you hold anything by mouth. So you'll probably want to use injections, like she's on IV pantoprazole. And injections are also suitable for large molecules that can't be absorbed through the oral route. Things like insulin I mentioned, or like heparin, another large molecule that can't be absorbed through the stomach. With IV medication, so it's a rapid effect, you could give a single dose or a bolus for like a one kind of quick effect, or then continuously infuse, say, a lower dose over a period of time. Subcutaneous is more rapid than by mouth, and IM is quite easy to administer, and you can give large volumes of up to 3 mils versus subcutaneous. So the route that we choose is important, and that's where if we look at, say, a drug monograph, we'll see different instructions based on the route. When we use a subcutaneous injection, we're trying to aim for the subcutaneous tissue here. And when we go intramuscular, we're going a little deeper into the muscle. Which route we use is going to affect the pharmacokinetics. So if we use the IV route, we're going to have a rapid absorption and a rapid peak and a higher peak for, say, IV midazolam. And then for the subcutaneous, we're going to have a lower peak, but like a smoother curve. So with the IV, this is quite a high peak. So somebody might become quite sedated, and seniors may be more confused. So in some cases, if we could use subcutaneous, this may be more ideal, this more gentle curve. And you can see there's a difference in how much medication is actually reaching the bloodstream for a bioavailability in the intramuscular, versus the IV. I had said subcutaneous. Subcutaneous would be sort of similar, but intramuscular. So absorption time. So the amount of time that it takes to reach a certain concentration is going to vary by the route of administration. So we know that IV is going to be the fastest, and then intramuscular. And then looking at this graph showing oral and subcutaneous, it's going to depend a little bit on the medication itself, and then rectal slower. When we think about concentration, one term that we can use is the Cmax, and that's the highest concentration of a drug after administration. So we can see that the Cmax varies here with each route of administration. So the maximum concentration is highest with IV, and then IM, and then subcutaneous. So each route would have its own Cmax. And interestingly, the Cmax is higher here for intramuscular versus oral. So I was thinking about when we give intramuscular, say, lorazepam or olanzapine to our patients who are agitated, it's going to work quickly and have a higher peak concentration, which can have pros and cons depending on what you're trying to do. Oh, I just lost my screen. 1 second. I just couldn't see anything on my screen. Bringing it back up now. Okay, we've just about got it.
Mhm.
Oh, it's okay, there we go. Okay, we're good.
All right, there you are. Good.
Yeah, not sure what happened there. And then so this is the maximum concentration, and then the T max is the time that it takes for a medication to reach the maximum concentration. So see, the time to reach the maximum concentration is quick with the IV, and then a little slower with IM and subcutaneous, and so on and so forth. So the Tmax is rapid for IM and IV, and then slower for rectal and PO. So when we think about drug absorption in older adults versus younger adults, it's going to be fairly similar overall to younger adults. But older adults may be on things like PPIs or have gastritis, which could increase the stomach pH, so it's a less acidic environment than usual. Having a less acidic environment in older adults may lead to some early release of medications with enteric coatings, like aspirin, for example. So the medication is released earlier than intended into the stomach, and then this could lead to some stomach irritation because these enteric coatings are aimed to try to limit those kinds of side effects. And then gastroparesis, so slowing of motility, or anticholinergic medications may slow the transition time from the stomach to the small intestine and delay absorption into systemic circulation. So after a medication is absorbed, it's distributed, and it's distributed into the blood and then into various tissues. And where the blood and to what extent, or sorry, where the medication and to what extent it's distributed into different tissues depends on blood flow, the chemical properties of the medication itself, like how soluble it is in blood or water versus into fat tissues. The more soluble it is in fat, it'll tend to prefer to be in fat, and the more water soluble it is, it'll prefer to be in things like muscle or in the bloodstream. And in addition to being distributed kind of outside the blood, medications also bind onto proteins like albumin. And if a medication is bound onto a protein molecule circulating in the blood it isn't active. It's only if it's detached from a protein that it can interact with receptors to have an impact. When we think about distribution of medications in older adults, they tend to have a higher proportion of fat to muscle, and fat soluble medications may stay in the fatty tissue for longer than younger adults. So we want to be aware of that with medications or substances that have a propensity to accumulate in fat, things like diazepam or marijuana. May be even more likely to be distributed to fat in older adults and take even longer to come out of the fat and then also be eliminated. So they could potentially accumulate if used at higher doses, especially. Older adults also may have less total body water, so they also are exposed to higher concentrations of water-soluble medications, things like digoxin or aminoglycoside antibiotics. And also, we commonly see that they're protein deficient. So in the case she's has a low BMI, she may have a low protein. So she has less protein, say, in her blood, and then less medications are bound to these proteins. So there's more free drug available to interact with the receptors and have effects and side effects. The volume of distribution, so it's kind of like a measure of just how much or little medications being distributed into fat. The higher, the more it's being distributed into fat, and the lower, the less. Really can vary significantly with medications. So you can always look it up if it's something you're interested in. Around metabolism, so after a medication is in our system, then we want it to be eliminated at some point. Things are metabolized and eliminated. And most drugs are metabolized by the liver. There's not that many that are just eliminated directly through the kidney. Usually they need to be metabolized to some extent first by the liver. But then there also can be some metabolism of drugs, not just in the liver, but in the blood itself, in the kidneys, or in membranes, like in the intestines. In older adults, polypharmacy could lead to drug interactions and on adverse or unintended effects. And the risk of a drug-drug interaction substantially increases when taking multiple medications. Around metabolism in the liver, this is done by enzymes, and medications can inhibit, so slow down the metabolism of these enzymes, or it can speed it up depending on the medication and what combination you're taking. Um, and in addition, in older adults, they may have slowed liver metabolism due to a smaller liver itself, less blood flow to the liver, and less production of enzymes that metabolize drugs within the liver. So this means that doses may need to be reduced in patients with compromised liver function and compared to healthy patients. I'm only going to briefly touch on metabolism in this presentation, but if we take a medication, so most medications are going to go through this process, and they're going to be modified by the CYP P450 enzymes in the liver, which take the medication and add different side chains or modify it chemically to be more suitable to be eliminated, say, by the kidney, by making it more water soluble or hydrophilic. When we change a drug from one kind of chemical structure to another, we may switch it into a metabolite that's also active and could contribute to side effects. So that's something to be aware of, are active metabolites. This production of these enzymes, our CYP enzymes, decreases in older adults to kind of a greater extent than this other type of metabolism that really we don't tend to talk about that much, even in pharmacy school, but it's conjugation reactions. So other modifications to drugs to make them more soluble in water to be more easily excreted by the kidney. So when we think of drug metabolism and how things are broken down, I think initially I would have thought that things are just gradually broken down in a linear fashion. So each hour, the liver would be breaking down so much at a time. And this is actually how alcohol is broken down, that if somebody has 10 drinks, then about 1 drink per hour is removed from the system. And that's called zero order kinetics. But actually, most medications are broken down with first order kinetics in a way that the rate of the metabolism or breakdown and elimination is proportional to the concentration of the drug. So, initially, say in the first, if we thought of each of these as an hour, in the first hour, we might drop down to 50%. And then in the next hour, a lower kind of amount is broken down, but it's another 50%, and so on and so forth. And that's called the half-life. And for every half-life, the drug concentration reduces by half. And I have another slide on this. So thinking about half-life and half-life in older adults, half-life is the time that it takes for the body to reduce the concentration by half. So this medication has a half-life of 1 hour, or and if the concentration was 1 initially, it would be 50% after 1 hour, and then 25% remaining after another half-life 2 hours, 12% after 3 hours, 6% after 4, and 3% after 5 hours. It takes 5 half-life, so around this point, we're saying that the medication is considered eliminated, even though there's the smallest amount there. And this half-life is often prolonged in older adults, so it'll take more time to break down each 50% due to changes in pharmacokinetics. And thereby, medications can have longer lasting effects and side effects in older adults. I'm just going to check for my time. Okay. So, looking at renal elimination and clearance in older adults, um, older adults have slower renal elimination, declining renal function. Our renal function will decline normally with aging by about 8 mils per minute for each decade after the age of 40. So if our GFR is 100 mils per minute at age 40, it's going to be 84 mils per minute at age 60, even if we're healthy. And then you can add on top of that things like an AKI or kidney disease, which could further impair renal function. And thereby we may need lower doses or less frequent dose administration as a result. With medications, one thing to think about is the onset of action. So we think about how long does it take between when we give a medication and for the therapeutic effect to begin. So that's the onset time. And the duration is how long that the drug produces a therapeutic effect. The onset of action can sometimes be a little tricky to find, but I find Lexi drug good to find the onset of action, but Dynamet or Micromedics might also be good. And they provide information on a lot of the pharmacokinetics as well. So pharmacodynamics is the next part, and this is really just like, medications having their effects interacting with receptors and their mechanisms of action. A drug action involves the interaction at cellular level between a drug and cellular enzymes. Drug effect is the response resulting from the drug action. In older adults, the effects of drugs at similar concentrations may be similar, smaller, or greater than in younger people. So the effect of drugs is usually going to be greater in older adults at the same dose, but in some cases it could be smaller due to changes in their receptors. And older adults are particularly sensitive to anticholinergic effects. So when we think about pharmacodynamics and receptors, we're thinking about the actions of drug on the body. The concentration is going to impact the degree or magnitude of the response of the drug. So higher doses or concentrations are going to usually have a bigger effect. Whenever we give a drug, it'll bind to a receptor and form a drug receptor complex. And then once the drug is bound to the receptor, like here, then this is when we will start having a biologic response. And this is called signal transduction. So the drug is stimulating the receptor to cause a signal within the cell. We're not going to go into details, but drugs can bind to all kinds of different receptors and have different impacts. And once they bind, then it can lead to a lot of changes within the cell. And these changes could be quite fast, or they could take more extended periods of time, like days, for example. So when we think of drugs binding to receptors, some medications are agonists. So they interact with the receptor and they produce an effect or an intrinsic activity. A full agonist is going to bind to a receptor and produce a full response similar to the endogenous ligand. So let's say if we had dopamine in the brain bound to its receptor, it will have an effect. And then if we give levodopa in Parkinson's disease, it will bind similarly in an agonist fashion to dopamine and have the same effects and hopefully improve movement. Partial agonists are going to have a partial response, so they activate the receptor to a degree, but to a lesser extent than the endogenous ligand, like Abilify is acts on receptors and causes a partial response on the dopamine versus dopamine itself. So it's less than dopamine in the brain at the endogenous ligand. So it's a partial agonist. And then inverse agonists have the opposite effect to the agonists. When we think about antagonists, they're going to bind to the receptor and kind of block it. So there'll be limited activity and prevent a response from occurring. And an inverse agonist, as I just said, has the opposite effect. So let's say in our body, histamine was binding, then it would be histamine at its own receptor would be an agonist and cause you maybe to have like itchy eyes or runny nose. And then when we give an antihistamine, it does the opposite and alleviates those symptoms. And it's an example of an inverse agonist. Thinking about mechanism of action. And so mechanism of action is a term to describe how a medication works in the body. And mechanisms are often through interacting with receptors and causing an action. So if we were to think about morphine, it's an agonist, so it binds to the opioid receptor. So you could have endogenous opioids, or you could give like a medication like morphine to try to alleviate pain. It's going to bind to the receptor and then have various cellular effects, leading to inhibition of transmission of nerve impulses along the pain pathway and improving pain. So you can see that these mechanisms, they sound quite simple, like just by alleviating pain, but there's a lot of cellular processes going on behind the scenes. I think I'm going to skip this just in the interest of time, but I had a video on efficacy versus potency just to cover some other concepts. So the therapeutic index, when we give a medication, we need to achieve a certain concentration to have the desired effect. But it's a balance. We want to have the therapeutic effect. So in this graph, about half of people with this medication would achieve a therapeutic effect here. Some people might need a higher dose, and some people might need a lower amount to have the therapeutic effect. But if we give too much, then we move into a toxic effect where there may be harm done for the patient. Like with warfarin, we want to make the blood a little less thin so that they don't have another clot. But then if we go too high, then they might have a bleed. And this sort of index, or the ratio of the therapeutic dose and the effective dose and the therapeutic dose is called the therapeutic index. And yes, so it's the ratio that produces, toxicity to an effective response. I was trying to think of TD and ED. So ideally, you want the therapeutics index to be high, meaning that you could give quite a bit more medication and not have a toxic effect, but not all medications work that way. So it's important to be aware. Things that can be quite safe at high doses are things like amoxicillin, but things like warfarin or lithium can move into a toxic range, even slightly above the therapeutic range. This is another way to show that ideally, the window would be large for therapeutic, in between having an ineffective and a toxic effect, but sometimes this is narrow and we need to be monitoring for toxicity and effectiveness. Introducing tolerance versus dependence. So tolerance is when somebody has a decreased response to a drug over time. The patient will require larger doses to have the same effect. Tolerance is just like a normal thing that happens with medications, things like opioids, things like benzodiazepines. You're going to need a higher dose to have the same effect over time. And then dependence is different. It's when you have a physical or psychological need for the drug. So you could have withdrawal symptoms and have a physical dependence, or craving, tension, and anxiety and have a psychological dependence. touching on drug interaction. So this could kind of fit with the metabolism part as well. So sorry if it feels a bit like it's jumping around, but medications can interact in different ways with pharmacodynamic ways. So at sort of receptors, or pharmacokinetic, like with metabolism. So thinking of medications, if we give two medications with similar actions, then they could have additive effects. And so things like acetaminophen and ibuprofen, we could use both of those to have an additive effect for pain and have more relief of pain than with either agent alone. When the effect is more than what you'd expect, just given the two together, if it kind of jumps up even to a higher degree of effect or risk, then that's called a synergistic effect, or can be potentiation. So things like alcohol can be sedating and lorazepam can be sedating, but together they can be quite dangerous and lethal. Similarly, with alcohol can be risky, and as well as acetaminophen, but high amounts together would increase your risk of liver toxicity. We want to be careful about using medications with antagonistic effects, because one medication could cancel out the other effect of another unintentionally. But in some cases, we might do this intentionally. Like if someone is overdosed on hydromorphone, then we might use naloxone to reverse that. Medications can also interact and interfere with absorption. So, for example, if we give Tums and Synthroid together, the Tums may bind up the Synthroid and make it unavailable for absorption. Or they can increase or decrease metabolism or excretion. So, one drug may interfere with liver metabolism, increasing or decreasing it, and one may impact renal clearance or kidney function. So thinking about examples, NSAIDs plus ramipril plus lithium could lead to decreased renal clearance of each other, especially we'd wonder about lithium. And then carbamazepine can induce or speed up the breakdown of quetiapine and make it less available for its antipsychotic effect. With drug interactions, they're really hard to keep track of in your head. So I really just recommend using a resource like Micromedics or LexiDrug, or ideally both, especially if someone's on multiple medications. Or you might want to look at drug interactions if the person isn't improving to the same extent as you expect. So I did see a patient who was on this combination of carbamazepine and quetiapine, and it wasn't realized that the carbamazepine was chewing up all the quetiapine. So they weren't really getting treated with as much quetiapine effectively as we thought. And there's all kinds of interactions, as we had just said. This could lead to things like serotonin syndrome, QTC, prolongation, sedation. So just definitely recommend checking things out. And if you're interested, if let's say it's important that ideally someone's taking two meds and they interact to a high degree, but you want them on both, then I'd recommend checking both sources and also reading the additional information on the documentation or literature on the interaction to see how convincing it is and how serious it actually is, and then using your clinical judgment from there to make decisions around if you're going to continue this regimen or make changes. And in the chat, if you guys wanted to put any other resources that you use for checking drug interactions, that would be great, because maybe there's something that you have found helpful that I don't know about. So coming back to our case, so she's 85-year-old female with a GI bleed. She has hypotension, AKI low, hemoglobin, she's thin, some liver disease. So some things to think about for her around this presentation. So she has advancing age. So she's going to have a decreased renal and liver function from age alone, as well as the AKI and her liver disease. She has a low body mass index. So she's actually going to have quite a lower volume of distribution overall. She may be having some impaired hepatic function from her NASH, so consider checking her liver function and adjusting doses of her medications appropriately. And to check dosing based on these sort of indications, I would check things like the monograph or up to date or micromedics. These were her medications: sertraline, bupropion, lorazepam, ramipril, ibuprofen, Benadryl, and aspirin. So, thinking about her case, starting the ibuprofen for pain might have increased the risk of GI bleed. Also, she's taking aspirin, and SSRIs can also contribute to bleeding risk. The ramipril and ibuprofen may further reduce the renal function with the AKI, so we're going to want to probably hold those for a little bit, depending on how significant the AKI is. We're going to use IV pantoprazole because it's going to bypass the GI bleed and it has a rapid effect, and you can use a continuous infusion. Looking at drug-drug interactions, the SSRI and bupropion could both impact seizure thresholds. Looking at drug interactions, say on micromedics, you might see that bupropion could inhibit CYP2D6, so you may want to decrease her sertraline dose. Bupropion's renally cleared. She has an AKI now. You may need to reduce her dose. She's a senior, and with lorazepam and diphenhydramine, these can contribute to sedation and delirium. And we're probably going to recommend that she discontinue the diphenhydramine because it's anticholinergic and limit the lorazepam. So that is my presentation. And if you have any questions, I'd be happy to try to answer them.
Thanks so much, Lauren. That was excellent and a wonderful review of pharmacology, which I only keep half in my brain. I must say I also have to look up all the interactions each time. There's only a few I can remember straight up, but it is good to have those resources and a review. Guys, if there's any questions or comments, you can put them in the chat or raise your hand and we can see if we can unblock you. How's that? There are 82 very quiet people here, Lauren.
Well, yeah, making it easy on me, but thanks. I'm impressed to see 80 people. I did not know what the turnout for these presentations were, so
Yeah, it
thank
does
you for
vary, but
joining.
this is a good number.